Hey guys, it's Dr. Steve. Welcome to another episode. Experts estimate that about 400 physicians in the U.S. take their life every year. Physician burnout, it's a lot more than workplace stress. It's becoming a major health issue that threatens the U.S. healthcare system. In 2011, the Mayo Clinic found 45% of physicians reported effects of burnout. By 2015, just 4 years later, that number shot up to 54%. And today, it's anyone's guess. On this episode, I'm bringing in two top experts on the cutting edge of physician burnout research and management, Doctors DeChant and Diane Shannon. They wrote a book, Preventing Physician Burnout, and guys, it is eye-opening and stunning. There's huge problems today in hospitals, health systems, and physician offices on the front line of care. We're jumping headfirst into the heat of physician burnout, right here on Red Hot Healthcare. Let's go.
3-1 and 21 and north. All engines respond.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com. It's my privilege and pleasure to welcome two outstanding leaders. They've made it their mission in life to tackle physician burnout and do all they can to not only raise awareness, but offer significant help in overcoming what's become one of the biggest threats in healthcare. Dr. DeChant is the Deputy Chief Health Officer with Simpler Consulting and IBM Watson Health. Formerly, he practiced medicine for 25 years with 30 years of health management experience. He's passionate about improving the lives of clinicians, staff, patients, and leaders in healthcare organizations. Dr. Diane Shannon is a former internist turned physician advocate. She's a change agent and a freelance writer centering on patient experience, communication, safety, EHRs, and teamwork. I want to thank you so much for taking the time to come on Red Hot Healthcare.
Thank you, Steve. It's a pleasure.
Thanks, Steve.
Well, I want to jump right in and get into the meat of the matter. How did you both get into physician burnout, this area of physician burnout, which is, as of 10 years ago, was barely a blip on the map, and now, of course, it's so widely known and it's such a pervasive issue. Maybe, Paul, you can start off with how you got into this.
Sure, Steve. Thanks. When I started in practice after residency back in 1983, really from that point forward, I continually found challenges, little problems that would go wrong during the course of a day trying to take care of patients. Usually I would speak up, and I ended up getting into management positions because once you speak up, you get put on a committee and then you get asked to be a medical director and you kind of move up the chain that way. As I got further up, I began to see, particularly after the introduction of the EHR, that all of us were spending far more time trying to get through our day and having more struggles doing it and greater frustrations with that. And I began to work more formally on process improvement around that. It wasn't until about late 2000s that I really started hearing about lean as an approach to doing that work. And then when I became the CEO at Sutter Gould Medical Foundation in 2009, I actually saw a formal presentation on lean as a way to help improve the conditions for physicians and the workflow through a clinic. And at that point, got engaged with Simpler actually to help the group that I was leading through that process. And once I got engaged with that, we actually built our lean transformation around the theme of returning joy to patient care because we knew docs were suffering with all of these challenges. So many changes have happened in the last 10 years where each one, not intentionally, is designed to create problems. They're all well-intentioned, but they add one more burden, as I like to describe it, one more straw on the camel's back. And we're now at the point where there's too many straws and people are starting to break.
Diane, you have an interesting background into this as well, and I'd like you to share that with our audience.
I am an internist. I practiced for only 3 years and left about 20 years ago. At the time that I left, I only knew I needed to, despite the fact that I really loved patient care. But the toll it was having on me physically, in terms of insomnia, in terms of other health effects, I just knew I needed to leave. And I was lucky in that I was able to transition into writing, first for a communications company, and then after 3 years there on my own. And it wasn't until about 5 years ago when I was writing an article about the connection between the physician wellness and the patient experience that I ran across the definition of professional burnout and realized that is what had happened to me. In all those years, I just didn't have a name for it. I didn't know there was such a thing. And after a bit, I kind of got my courage together and I told my story, and it was posted on a National Public Radio website. After that, physicians began contacting me to tell me their stories. And so often what I've heard is that they didn't realize that anyone else felt the way they did, but they recognized in themselves that they wanted to stay. They loved being clinicians, but they were finding it was just wearing them down.
For quite a while, when administrators and other people outside of healthcare would talk about this phenomenon, would talk about physician burnout, they often thought of it, and I've read in past articles that they thought of it as really just highly paid professionals that, they were dissatisfied with the way things were changing, and they just were unhappy with it. But that's not even touching the surface of what physician burnout is and how deep it goes. Maybe you could both give us your best explanations of describing physician burnout. If you were talking to, say, a 14-year-old, how would you describe it?
What I was so interested to learn is that there is a great deal of research about professional burnout. And it is not simply being tired. It's not simply needing more vacation. It's not simply being dissatisfied. And it's not depression. It actually is a reaction, a response to stress in the workplace. That is how it's defined. And it has a number of manifestations which have also been described. It's a very well-described phenomena.
So this is Paul. I would add in, we did come to realize that what drives burnout is an interaction between the worker and the workplace. We put highly motivated professionals into a work situation where they're unable to succeed without constant vigilance and focus, always going above and beyond. And that becomes unsustainable. And so people may think of it as the physicians or other healthcare workers complaining, but they're complaining because they're motivated to provide great quality care to their patients, and they're unable to do it without putting in Herculean levels of effort.
Yeah, and we're going to get into that within the show here. Just how much physicians do work, especially today, is often, it's really underappreciated, I think, by the general public. I think sometimes they look at physicians and they have a mindset of, oh yeah, they make a lot more money than we do, and they work hard, but boy, they make a lot more money. I think that through this show here, we're going to be able to just give our consumer-based audience quite a bit more knowledge about that and what goes on the inside. Let's move into some of the symptoms. We talk about burnout and we talk about the three major symptoms. And from the book which we're going to reference, and the book that I'm talking about is Preventing Physician Burnout. It's a book that's authored by both doctors on the show here. We'll talk about it at the end of the show as well. Definitely go out and get this book. It will give you the best insight if you're a hospital administrator, if you're a physician yourself, if you're a frontline healthcare worker, a non-clinical physician, if you want to be a more educated consumer and know what goes on the inside. This book is a 5 out of 5 and gets my strongest recommendation. So let's talk a bit about burnout symptoms. There's three of them. There's three major symptoms that you talk about in the book. And the first would be emotional exhaustion. The second is depersonalization. And the third is inefficacy. So I want to focus mostly on this question on the depersonalization aspect. Diane, let me just reach out to you on this here. Let's talk a little bit about that. Talk a little bit about depersonalization with the physician and the effects that come from that.
Right. And I will say I experienced all three of these in training and in practice. And I'll just say the emotional exhaustion is that sense of being completely spent. There is absolutely nothing left. And it also has a cognitive component where it's more and more difficult to make decisions. The depersonalization is also sometimes referred to as cynicism. And it's a distancing from the emotional aspects of the work. And for physicians, that can begin to look like seeing the patient as yet another case or another number or another admission. And the third symptom is inefficacy, which is a low sense of personal accomplishment in one's work. So feeling like what you're doing doesn't make a difference. Now, what I was so interested to learn about depersonalization is it's actually a coping mechanism, so that when professional workers begin to feel exhausted, so they're feeling that first symptom of burnout, one of the ways they try to compensate to remain effective at what they're doing is to separate from the emotional part of it. And for me, when I learned that, it was kind of a comfort to think that it's not that I had become a cold, non-caring person. It's that I was experiencing one of the manifestations of burnout. And I'll also say that those symptoms are ones that have been described in research for many years, since the 1970s when professional burnout was first described by Christina Maslach and other researchers.
Yeah, and I know that comes off to the patient seemingly as perhaps maybe not enough empathy, that, well, my doctor just didn't seem to care, or maybe even to the care staff that works with the physician. I mean, it could come off, pretty much like non-empathetic or maybe without compassion. Am I right on that?
Definitely right. And I've spoken with patients and family members who have had that experience, and even with a physician who several years ago was very empathetic and had great communication skills. And then over time, they watched as this physician became burned out, and that experience completely changed. And I've heard from patients and families who have chosen to leave a physician that they really had previously enjoyed partnering with, because the person was burned out and simply couldn't provide that kind of empathy, and that healing interaction was not happening in the way that the patients and family members wanted.
Yeah, these are all great points, and we're going to get into just how interweaving all these effects are. The other thing we talked about off air too is just how much physician burnout, it not only affects the culture of an organization, but now you get into all these other aspects of, physician recruitment, retaining physicians, the finances of an organization. Some of the stats get up into the hundreds of thousands, if not, in some cases, the low millions in terms of the effects it can have just with one or two of these physicians. That leads me into my next question. And really, Paul, I want to ask this of you. I'm familiar with employee engagement, even outside of healthcare. I have a lot of connections in the HR arena, and employee engagement all across the landscape is getting tougher and tougher. I think some of the studies now talk about that only 33% of all employees are engaged in or enjoy the work that they do and enjoy the company they do it for. So some of this includes burnout, but really there is a uniqueness to burnout for physicians. The studies all point to it being much greater. In fact, I think it's twice as great compared to the general population. And maybe I'd like to get your insights on what do you think accounts for that? Why do you think the burnout level for physicians is just so much higher than the general population?
Well, there's a number of factors. First of all, anyone in a caring or social type profession is at higher risk for burnout because of the nature of the work we do. But the challenge that's changed in the workplace in healthcare in the last 10 years has really been significant, starting with the introduction of the EHR, which completely changed the way a physician interacts with a patient and forces physicians to spend much more time with their fingers on a keyboard and their eyes on a screen rather than connecting with their patients. But with that came a number of other regulatory issues where the government now requires what's called meaningful use, ways that we demonstrate that we are indeed using the EHR correctly. Payers are using the information in the EHR to demand more prior authorizations and to deny payment of claims. We have a lot more quality measurement happening, both in terms of the quality of the care that's delivered as well as patient satisfaction scores, which can have a big impact on how we do our work. And patient satisfaction's always been something that's bothered physicians because they think their patients are harder to please than others. That has changed over the past few years because patients have actually gotten sicker, they're getting older, and they're more diverse culturally and linguistically. So we need to use more translation services as we're seeing patients now than we used to, which adds to the challenge. And then even those patients that are culturally coherent with us, many of them have consulted Dr. Google before they arrive, and they come in not asking for our help as much as telling us what they want us to order for them. Adds to that, oftentimes some of these orders or requests are for pain medicines, and with the opioid crisis, now to order opiates in many states, we need to consult a statewide database before we actually place that order. So all of these things are becoming bigger issues, which makes it harder to do well on those patient satisfaction scores. We could get rid of those, but patients are also rating us on Yelp, so it's not as though any one of these issues is a big factor. Add into that even further now, we're seeing more violence in the healthcare workplace as well. Put all that together in a world where we're seeing lower reimbursement for each service we provide, and it all adds up into a big burden. All of those changes are impacting the workplace and driving the increase in burnout.
Yeah, I think one of the things, too, that people don't realize is it's not just that doctors, and I'm not trying to put doctors on a pedestal here. Doctors put years into training and work, sometimes up to 12 years of college after high school, and you're talking about people that put off a lot of personal milestones, right? They delay their marriage, they delay having kids, and you're talking about a world of healthcare today with, the treatment levels are more complex, the diagnoses are shooting up in terms of complexity and numbers, documentation that's needed today is going up. You've got EHR instead of paper records, and obviously that's, more boxes to click, and you have to click it right. And then even the number of medications and medication interactions. Not to mention, we're moving from fee-for-service to value-based care, so it's not just doing the service and sending it off. It's now saying, okay, we're going to take on the risk, not just for patient satisfaction, but we're going to take on the risk for outcomes. So all of that is getting loaded mostly onto the physicians on the front lines of care here. So I've just even read a stat too, Paul, maybe you can just chime in, but just with the advent of EHRs coming in, physician productivity has actually dropped down between 20 and 40%. Is that right?
Yeah, that is correct. There's statistics that certainly show a drop of 16% in productivity for family physicians between 2010 and 2016. And many physicians, especially younger ones now, are coming out of medical school with $300,000 of debt. So not only do they put off, other milestones in their lives, but it's very hard for them to think about putting a down payment down on a house when they've already got the equivalent of a home mortgage in educational debt.
Diane, look, I read the book, and one of the things that surprised me was how physician burnout trickles down. It's really more than just the physician being affected, right? I mean, you're talking about it trickling down into all facets of the organization, and then even further than that. I know this is something that is really, strong in your heart, but break it down a little further. I mean, how extensive are we talking about? How wide-ranging does it go?
It trickles down, just like you said. If you think about the team working around a physician who's experiencing burnout, they are going to be affected by that. And there's research that shows that burnout is associated with effects on patient care, specifically with medical errors. And if you consider what is it like, as I said before, to be speaking with someone who is experiencing depersonalization, that patient experience is just not going to be the same. And if we all sit back and ask ourselves, what do we want when we're a patient or when one of our loved ones is a patient? We want a clinician who is able to be fully present, who is, not experiencing exhaustion and depersonalization and inefficacy, but is resilient and is thriving and is able to make that healing connection with us, right? That's what we all want. And burnout definitely gets in the way of that.
Right.
Now, if you think about it at a larger level, at the organizational level, there is a significant cost. Just the financial cost of replacing, recruiting, getting a new physician up to speed when one has left a practice to retire early or to go to a different career or a different organization. It's estimated that costs somewhere between $250,000 and some estimate even higher than that. So for every physician that leaves, you're looking at about $500,000.
Man, that's amazing.
Amazing. And if you think about then, if it's a primary care physician out in the community who would be directing patients to a particular hospital, that hospital has now lost the revenue that goes along with all of those patients who need to be admitted. And then there's also, the cost on the effects of those other important metrics that an organization cares about that might be affected by physicians who are burned out, like patient experience scores. And we need to remember, and this is the part that I hear about so much from individual physicians who contact me, is the personal effects of burnout. And it has been associated in research with substance use and alcohol abuse and with suicide ideation. And this was something that absolutely shocked me when I heard this about 4 years ago, that physicians have a much higher suicide rate than the general population, and that especially female physicians, and that it translates into somewhere between 300 and 400 physicians every year that we lose in this country to suicide.
Wow.
And it's so such a huge consequence to that physician's family, to the community in which they were training or practicing, has a huge long-lasting effect and is really a tragedy.
Yeah, it sure is. And we've always thought of doctors as somehow, superhuman. They're smarter, they're stronger, they're more resilient. But the fact of the matter is, when you peel all that off, no matter how much education and experience and how much passion and energy is put into becoming a doctor and then becoming a good doctor and the day-to-day experience, you have real human beings underneath these shells here. And, you just point that out so clearly in the book, both of you. Paul, I want to just shift over here to a thought that I had, and this I carried through me with the book a little bit here. Back in the 90s, when we started seeing health systems growing, we really started seeing the business of healthcare coming out more. Doctors always made pretty good money, certainly for the last 40 years. But when we started getting into the 90s, we started seeing hospitals becoming health systems, and then health systems really growing out those geographical footprints of patient coverage and service. And they did it right through acquisition. They acquired practices and they acquired other hospitals. And at the end of the day, these physicians were acquired, and I see it or I feel it through the book, that both sides seem to make assumptions, almost like the business people at the health system almost felt de facto that the physicians would just fall in line with what was typically top-down Sloan-style management. And the providers may have been sold a bill of goods when they were being acquired, but they may have erroneously believed that, hey, when we come on board, nothing's really going to change. Practice is going to work the same. I'm going to be calling the shots and running it how I've always run it in my practice. Am I reading into this wrong, or is there anything to this that maybe both sides made assumptions about how the other ones would simply fall into line, and that is some of the issue today?
So you're absolutely right, Steve. Both sides did have their impression about how things would be after an acquisition took place. And from the executive side, managing professionals is very different from managing average people in an organization, and particularly in healthcare, where the organizations are so complex. So there's definite challenges there. From the physician side, we've spent much of our collective physician experience up until the last 10 years or so without a lot of accountability for the way that we practice or for the outcomes that we achieve.
Right.
And that's changing, and that should change. But it's been part of it. That has happened at the same time that a lot of this acquisition work has happened. And so there's a big drive there.
Diane, your story is amazing. I just think you are such an incredibly strong person. A lot of people wouldn't have not just the innate insight, but also the guts to step away from something as you did, just knowing yourself and knowing sort of how this train was going to travel if you kept on the same tracks here, and you made that change. And as you reported and told us earlier, once you started opening up about it, you created a forum for other doctors too. Suddenly you start getting contacted. You start getting contacted just all over the place. Doctors are reaching out to you now and saying, God, me too, me too. Like, that's exactly what's happening with me, and I haven't been able to share it. Why do you think that physicians have traditionally been pretty tight-lipped about burnout?
I think there are a number of reasons, and some of it is that what you mentioned before about this sense that as physicians, we see ourselves and maybe others see us as perfect, as needing to be perfect, as invincible, as not having human needs. And when I think about at least my experience with residency training, it seemed to be that was the assumption, that you could go 30 hours working without a break, or you didn't need to eat at regular hours. And for whatever reason, that is part of the culture and tradition. And some things have changed, obviously, with the duty hour restrictions and other shifts. But I think there remains this stigma about admitting to any weakness at all, and whether that's needing mental health treatment, or feeling burned out, or questioning some aspect of your career, or simply having a really difficult experience with a case and needing to talk to someone about it. We seem to have this ongoing culture that within healthcare that says, just keep going. In understanding burnout, there is this tendency to think, both on the part of the individual and the people around that person, it is an individual problem. So let's fix the person. The person has the problem, instead of seeing that it's actually a reflection of what's going on around the person.
Yeah.
And it may be easier to see it that way, right? It's easier to say, okay, this is the problem, instead of it being a little more systemic and potentially a little more complicated to address. I will say that when I introduced myself as someone who has left clinical practice, people who are not in clinical medicine, so non-clinicians, will ask me, why did you leave? That they're interested in what would make you leave this profession. But when I introduce myself and it's a clinician, they almost always ask me how. They don't ask why. They understand why, because all of us have felt that frustration, that if it continues in those, the difficulties, the stress level, the completely frustrating and inefficient processes, that they can eventually lead to burnout.
They already assume why. They don't need that answer. It's just a matter of how. That's really powerful. And I think the other point I wanted to make on this too and ask you about, Diane, is, look, you're a doctor, you're working for an organization, and not just reflecting on perhaps your own ego or your own strengths or feeling weak towards that end, but now it's almost along the lines of, well, if I start telling people I'm depressed, what's that going to mean in terms of my employment? What's that going to mean in terms of the way other people look at me and my colleagues look at me? I mean, isn't that part of it as well, is sort of along the lines of just having personal security in being employed and not wanting to lose that camaraderie and that respect from the organization?
Yes, I think that is actually a legitimate concern. And depending on which state you're in, there are different regulations in terms of the medical board about what you need to report in terms of mental health treatment. And I think that's too bad. I think that is a disincentive for getting care. And when I've spoken with some physicians who have been burnt out to the point that they needed to leave practice for extended periods of time to recover, I think they would say, I wish I had taken the risk to go and get the help I needed, even if it meant an effect to my reputation, because it affects the physician in so many ways, and their prospects looking forward in their career, their relationships, their family experience. And so I think it can be very helpful to find out what the regulations are in your state. But from my experience, it's worth it to go ahead and get the help that you need.
Paul, once I turn on certain parts of my brain, it's a little hard to turn it off. And it probably, some people would say it's a benefit. Sometimes I'd say it's a curse. But I kept thinking throughout the book, amongst other things, what about other healthcare professionals? I mean, this is centered on physician burnout, and certainly physicians have to be counted for and they have to be recognized. We start looking at nurses. We start looking at, physician assistants, all the other people that are involved with care coordination, care delivery that are not physicians. And I started thinking to myself, what's the stats on their burnout? What about their efforts? What's happening with them? So let's say we could snap our fingers and tomorrow all the physicians are cured of burnout instantly. Well, what about if the rest of these people don't have their burnout addressed? And maybe you could talk about that a little bit. We had an interesting conversation off air on that.
Well, first of all, because burnout is an interaction between the worker and the workplace, and doctors and nurses and other therapists are working together as teams, of course, you can't turn off burnout for one component of that team and have it still be present for the others. We're all in it together. Regarding nurses, there's a survey from Kronos, which is an HR software and management support firm that they looked at nurses. In fact, they just published in May of 2017. And in their survey, they found 63% of nurses reported that their work had caused burnout. And they 44% worried that their patient care suffered because they were so fatigued. And 41% are actually considering changing hospitals to find a hospital that has a better environment in it. So nurses clearly are experiencing it. The other component is the leaders, the healthcare executives. They have their fair share of burnout as well. And I think one of the challenges we all have is we're all getting stressed. We have less and less reserves to step back as we interact with each other, to really listen to each other, to maintain a level of empathy for each other as we're trying to work our way through this process.
Your book leads us into what I believe is a major and well-needed solution that we're going to get into with lean, but maybe you can talk a little bit about why workflows have created what you call a toxicity. In the book, you call it a toxicity in healthcare environments.
What we're talking about is people having to go above and beyond to get their job done. And many organizations have this above and beyond award that they want to give to people who've given extra effort. But what we find is people are going above and beyond every day, all day long, nonstop. And that's what wears people down. And the reason is because they have to have workarounds for all of these barriers and frustrations that get in the way of taking care of patients. So when most people think of lean as a way to remove waste from workflows, and we certainly do that, but we do far more than that. And in order to do that effectively, we do need to completely change the way we approach and manage organizations. So first of all, to get docs engaged, I don't talk about it as removing waste. We talk about it as removing barriers and frustrations from our ability to take care of our patients, because that's how we all experience that. Secondly, in order to do that, that work isn't done by a committee sitting in a conference room somewhere looking at reports and coming up with great ideas. It's done by going to the people who are experiencing and living those barriers and frustrations and engaging them in their great ideas about how to fix that, how to get rid of those barriers, how to change the way things are done, and then rapidly testing it as we implement those. That work, to do that effectively and consistently over time and make it a culture, really does take a change in the entire management approach, where managers and leaders go from being what got them successful in the first place, their ability to come up with a solution for a problem and get other people to implement that solution, to changing to a way in which we become coaches and mentors, where we coach the people who have the problem to come up with their solutions and give them the resources to implement those solutions. And that's just a completely different mindset.
Ken, what you're talking about that I understand so well here is almost like workarounds, like going in and saying, we got to find a workaround. And, what if, this printer doesn't work right? Okay, well, let's write it out by hand. We'll just have to do a workaround. And, what if this is not up to speed? Well, we'll work around this. And, we'll put a piece of tape here and thumbtack it there and put a little glue there. And, I suppose this leads us into lean. I mean, what better way to start stepping into the science and certainly the benefits of lean? And Paul, I want to go ahead and just jump into this with you. why do you think lean has become such a powerful practice and really, as you feel very strongly about it, so necessary to combat burnout?
Oh, absolutely. And we build in ways where that is fostered and easier to do, and the whole group works together in that process. We do a lot of work with visual management where we're tracking either a problem or we're tracking the outcomes that we're getting. And we can see when things are going well, we know we're on track. It's great. When things aren't going well, we make it so we can see those easily. Usually we'll color those results red. When we see that red, red doesn't mean bad. It means there's where we need to focus our attention. There's where the opportunity is to improve. So we want to celebrate when we're off track because it helps us know where we need to work so that we can improve. That's a really different mindset. In most of our lives, we've spent our lives avoiding red. We don't want to get that F or that D. We don't want that red mark on our paper. So it takes a bit for everybody to say, oh, okay, red's not only all right, red, we actually encourage it. We want to proudly show off where we're missing the mark so we can focus our efforts there.
Oh, it is. And everything I was reading through started me thinking more about flattening that leadership, just flattening that traditional Sloan top-down model and saying, you're going to have a stake now in being a leader. But with your stake in being a leader, you're not just going to get a title. You may not just get a little extra compensation. You may not have to attend just a few more meetings. You're going to be responsible as a physician leader to go in and find those areas and then be accountable for having them implemented, right? I mean, it's not just the title and it's not just the extra responsibility in terms of being a leader. I mean, there's real follow-through as part of lean.
Oh, that's absolutely true. And the other thing that is very important, I think we may have touched on it somewhat, is that when there's a problem, the problem isn't because of the person who isn't trying to get the job done or is intentionally doing it wrong. People are especially, well, in almost every profession, but certainly in healthcare, are highly motivated to do the right thing. The problem is the way the system is designed, the way the workflows are designed that make it so hard that even though you're well-intentioned in doing your best, the outcome isn't what we're shooting for.
Yeah, you know what I like about the concept of lean also is that it really runs contrary to what one might superficially believe. Oh, the doctors are burned out. They're working 50 hours a week. The last thing they need is to have leadership responsibility put on them. That's going to be more on their plate. It's going to burn them out more and get them more frustrated. It's really kind of just the opposite, right? I mean, they're not looking for control as if they want to be a king and control the kingdom. They're looking for control because they know these problems, these workarounds, these inefficiencies, really need to be fixed. And it gives them not just confidence, but it gives them happiness to see problems being fixed, not just in patients, but in the processes that go towards the delivery of care for these patients.
I've thought about that a lot. In my current experience, what I'm finding is I try to help leaders understand how important it is to understand the real experience that a physician or a nurse has on the front line as they're caring for patients, and that they need to actually go to that place where the care is happening and shadow caregivers to truly understand it if they're going to be effective leaders. They'll give some lip service to it, but very few actually will do it and do it consistently. And yet it's the most powerful thing to change a leader's mindset.
Diane, I want to jump in with you here. We can talk about lean all day long and how terrific it is and all the benefits, but tell me about some of the frontline, some of the differences that inherently you've seen in the clients that you've worked with and those health systems and hospitals that have actually gone in and really implemented lean properly.
Right. Well, I'll tell you about one that Paul and I interviewed and Paul worked with to help them with their transformation. And it's a outpatient facility, a set of clinics in Northeast Georgia. And we interviewed in particular one of the physicians there. And he was just out of training for 6 years. And he talked about how he was really burning out, that the scheduling system was set up such that he would start in the beginning of the day. He would already be late, or the patients were coming in late to the time, by the time they got into the exam room. And it was a snowball effect throughout the day. If they had a case that needed more attention or there was a complication, that just threw off the whole schedule. And he was often running 45, 60, 75 minutes late. He would walk into the exam room and he felt so guilty that he'd kept the patient waiting. They were frustrated. So it was really not a great way to start that interaction with the patient or to spend your day. And not only that, he said he was spending 2 or 3 hours every night at home on the EHR and had young children. He had no life. And their organization went through a transformation for improvement using lean. And he talked about some of the things that they did. One of them was to really look at the scheduling system and to add in a little time at the beginning so that patients would come in a little bit earlier, 15 minutes earlier, so that they were prepared, and they were all prepared by the medical assistants in the same way so that the medical assistants could work with any of the physicians and it would be the same process. And so that they streamlined the things that could be streamlined, but they didn't change the actual practice of caring for patients. And they also added in some time during the day for documentation and just looked at some of those processes. And what he said was, in a very short amount of time, something like a month, he noticed a huge difference in what his day looked like. He was running on time. He says it's rare if he's running behind, and that at the end of the day, he's generally finishes work on time and goes home with either no work at all for the EHR or a very small amount. And I was so struck by a comment that he made to us. And he said, I've only been out of practice or out of training for 6 years. And yet when I was looking ahead, I couldn't imagine continuing in this profession. And he said, now I can picture myself continuing to work in clinical medicine for the next 20 or 30 years.
Yeah, just powerful, powerful stuff. And I know that throughout your book, and again, I cannot recommend the book strongly enough. It's Preventing Physician Burnout by Dr. Paul DeChant and Dr. Diane Shannon. They go over and over in the book about all the different improvements that have happened in different hospitals and health systems. And it's remarkable. I mean, it's almost as if it just reminds me of that image. And, I used to have this image on my computer of a man being blindfolded and literally having a pair of scissors next to his blindfold, cutting the blindfold off, and sort of like being unleashed to actually see how much more beautiful things are, or see what's been hidden all this time. That's the way I look at lean. I sort of look at it along the lines of it opens up this whole new horizon that, often remains hidden.
Exactly. And I think it was so inspiring to interview people from all of these organizations where they had experienced a change, and they could tell you what it was like before and what it was like afterwards. And, their experience is just so inspirational to hear, what is possible. It gives everyone hope to see that this sort of change in their daily work experience is possible.
So in wrapping up the conversation today, Diane, let's start with you. How do you see physician burnout and the quelling of that, the management of it, and perhaps maybe at some point we could even say the virtual cure of that happening? I mean, how do you see physician burnout evolving in the next 5 years from maybe the trends that you're seeing right now?
Well, honestly, I think it's going to depend on how much top leaders in organizations begin to get behind this and really understand how important it is. I'm not sure they're there yet, but I think understanding the cost, even if they're just looking at the financial part of it, the cost of recruiting and retaining physicians and nurses, and going forward, there is going to be more difficulty with trying to recruit. That may even lead us to a larger problem for our society in terms of access. As our population is aging, there's also aging of physicians, so more are going to be retiring anyway. And then when you add in the burnout and physicians leaving practice or retiring early, there's this potential for there to be a real problem with there being sufficient number of physicians in the country. So it could become a public health issue.
Right.
But I think that most important is organizations, I believe, the organizations that begin to understand how important this is, and that when you're working on the problems that are causing burnout in the first place, you're also working on the problems that are hindering you from excelling at some of the other metrics that organizations care about, like patient experience and safety and quality. So it all fits together.
Yeah, well said. Paul, why don't you take us to the end here, and why don't you give us your view on where you see physician burnout in the next 5 years?
Well, in the last 5 years, the focus on burnout has been to develop wellness and resilience training programs for physicians to help physicians cope. What I see happening beginning in the past year, and I hope accelerating in the next 5 years, is work to actually fix the workplace so that a highly motivated person can easily be effective by working in that workplace that facilitates their ability to do what's most important to them. Just starting to see momentum build in that way, and that's crucial. Every healthcare organization that can focus on that has a great chance of being successful in the long run. Every healthcare organization that stays focused only on resilience is likely to get into more and more trouble.
Well, guys, I want to thank you all for listening today to the show. I especially would like to just reach out and thank our guests, Doctors Diane Shannon and Paul DeChant. Thanks so much for coming on the show. We really appreciate you both making the time. An absolute privilege and pleasure. And again, the name of the book is called Preventing Physician Burnout, and you can find it on Amazon.com. It's got a green cover. Well worth the read. And you can reach Dr. Diane Shannon at mdwriter.com or through her LinkedIn at Diane W. Shannon. And you can reach Dr. Paul DeChant at pauldechantmd.com or through his Twitter handle, same thing, Paul DeChant MD. Thanks so much, guys, for being on the show. Appreciate the dialogue back and forth, the engagement, and wish you both the very best moving forward.
Thank you, Steve. It's been great.
Thanks so much, Steve.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.